Hello guys and welcome back to Count to 10. My name is Arnie and on today's MiniPod we're going to look at the fetal circulation, neonatal anatomy and neonatal physiology. It's a big topic to cover with a few SAQs that we have to go through, which I think are important both for the exam but also for clinical application. And we'll stick to our normal process of reviewing the learning objectives, looking at the SAQs and then looking at some opening viva stems related to today's topic. Unfortunately, this will be my last mini-pod for a while. I'm taking a mini hiatus focusing in on my part 2 exam, but I'll definitely be back with more podcasts in the second half of next year. We'll go back to our normal routine of going through a whole core topic, and I've also got some changes happening to the Sweet Dreams Anesthesia YouTube page with new videos that'll be coming up that will hopefully help not only the candidates that are studying for the Part 1 exam, but when you want to go back and review something quickly as well. So I'm really excited for the next part of Sweet Dreams Anesthesia and our so-called Phase 2 going into the second half of next year. But for now, I have to focus in on this Part 2 exam. With that said, we've got a pretty big podcast lined up today, a lot of topics to cover. So let's dive straight in.
1, 2, 3, 4.
Now, the first thing we're going to focus on is the learning objective. Describe the transition from fetal to neonatal circulation and the establishment of ventilation. This is a core learning objective that you have to know, and it's very easily examinable because everyone needs to know the shunts that exist in the fetal circulation. So the fetal circulation differs from the adult circulation in that it is in parallel rather than in series. It has 3 shunts that you must know of, and these are the foramen ovale, the ductus arteriosus, and the ductus venosus. To describe blood flow in the fetal circulation, we must start off at the placenta. At the placenta, there is 2 umbilical arteries that are going towards the placenta and 1 umbilical vein coming out of the placenta back into the fetal circulation. Counterintuitively, the umbilical vein has the higher oxygen content. Its partial pressure of O2 is 30 millimeters of mercury and its SpO2 is 80%. From here, the blood flow splits into the ductus venosus, which receives 60% of the blood flow from the umbilical vein, and then 40% goes into the left branch of the hepatic vein. The ductus venosus essentially acts as a shunt, bypassing the liver so that the liver doesn't use any of the oxygen. At the IVC, the saturations have decreased down to 67%. From the IVC, the blood goes into the right atrium, where 60% of the blood will go through the foramen ovale, and 40% will go directly into the right ventricle. In the right ventricle, the saturations of the blood is 50%, and the right ventricle will squeeze out blood into the main pulmonary artery, where only 10% of that blood will go through the lungs and into the left atrium, but 90% of that blood will go through the ductus arteriosus. This is the second shunt, which is created by a channel from the pulmonary artery into the aorta in the descending aorta. In the descending aorta, the saturations are said to be 60% and the partial pressure of oxygen is 20 millimeters of mercury. Going back to the right atrium, 60% of that blood flow that went across the foramen ovale went into the left atrium and then down into the left ventricle. Here, the saturations were 65% and the partial pressure of oxygen was roughly 25 to 28. So compared to the RV where the saturations are 50%, the LV has more well-oxygenated blood. And this is important because the ductus arteriosus is joining the aorta in the descending part. So it's bypassing the major vessels that go up into the cerebral circulation. We want the blood that's going to the brain to be the most well-oxygenated. So that's why it's important that the blood in the LV has better oxygen content than the blood in the RV, because this is the blood that will supply the brain and importantly also the coronary perfusion. So to summarize all these shunts, you start off with the umbilical vein. 60% of the flow from the umbilical vein goes through the ductus venosus. Then, as the blood goes into the right atrium, 60% of the blood here goes through the foramen ovale. And finally, the blood that gets pumped out of the right ventricle, 90% of that blood goes through the ductus arteriosus into the descending aorta. So you can say that the important features for the RV is that it's pumping against a very high afterload. The lungs are collapsed and squished, and that's why majority of the blood that comes out of the RV goes through the ductus arteriosus. On the flip side, in the LV, it's also pumping against a high afterload. But the LV is the main driver to supply the cerebral perfusion and the coronary perfusion. So here, we want the oxygen to be as high as possible. Now, what happens to these three shunts as we transition from the fetal circulation to a neonate? Well, we're moving from a parallel system to one that works in series. So just like a normal adult system, which is comprised of the pulmonary circulation and the systemic circulation, that's what we have to try to get to. So how do we get there? So firstly, we have the loss of the low resistance placental circulation. This happens because there's clamping of the placenta or the removal of the placenta. The effect is now our systemic vascular resistance has been increased. At the same time, the neonate is being stimulated and taking their first breath. As the lung expands and the oxygen levels within the lung start to increase, the effect of hypoxic pulmonary vasoconstriction starts to decrease. Now the pulmonary vascular resistance has decreased significantly, and therefore that gradient that existed to push blood through the ductus arteriosus is being lost. As a result, more blood flow is going through the lungs, going through the normal channels going into the left atrium and into the left ventricle. The combination of these two things, where the pulmonary vascular resistance has decreased significantly, the systemic vascular resistance has increased, now leads to the left side of the heart having a higher pressure and the right side of the heart having a lower pressure. All of a sudden, the pressure gradients have changed, and therefore the foramen ovale, which was open, now starts to close. This should close immediately after birth, but permanent closure takes around about 4 to 6 weeks. At the same time, the ductus arteriosus is closing. This is happening due to a combination of reasons. There's a higher partial pressure of O2, the neonate has taken their first breath, and then there is a big drop in the level of prostaglandins that are cycling within the fetal circulation. This is why if you want to keep the ductus arteriosus open, you give a neonate an infusion of prostacyclin. But if you want to close it, you give them an NSAID like indomethacin. Now, physiologically, the ductus arteriosus should close within 10 to 15 hours, but permanent closure takes around about 2 to 3 weeks. This can be a really important time frame when you want to have those situations where you want to maintain a fetal circulation. These situations typically arise when you have complex congenital heart disease, typically where you have a cyanotic heart disease, so a right to left shunt, not a left to right shunt. And that's probably too complex, and I don't think you'd ever get asked that in the primary exam, but it's certainly an important principle when you're looking at the Part 2 exam, and even then you'd be pretty hard done by if you got asked that. The last shunt is the ductus venosus, and this is a tricky one. It closes a few hours after birth, but we don't know the exact mechanism why it closes. Because of the closure of the ductus venosus, there's decreased venous return via the IVC, and therefore the right atrial pressure is further decreased, allowing the foramen ovale to close. The ductus venosus becomes the ligamentum venosum on the liver. It helps to separate the liver into the left and the right lobes. So that's our initial overview of the fetal circulation. It's not that complex when you just remember you have 3 shunts, and if you remember what side of the pressures are higher. Typically, in a fetus, the right side of pressures are higher, and then as you transition to a neonate, the left side of pressures become higher. Now we'll move on and look at the neonatal anatomy. So this comes from the learning objective, describe the anatomy of the neonatal airway, how this changes with growth and development, and the implication for airway management. To start off, we first have to define a neonate. This is the first 28 days of life. When we look at anatomy, we can have subheadings on how we want to classify different things. Typically, when I think of neonate anatomy, I just imagine myself looking at the neonate. So I think of the external features, I think of the upper airway, I think of the larynx, and I think of the lower airway, and I think of the chest. With each one, there is a certain change that happens or a certain distinct feature which separates it from an adult airway. Externally, neonates have a relatively larger head, they have a prominent occiput, they have a short neck, and their angle of mandible is not as defined as an adult. In the upper airway, they have no teeth, they have a relatively large tongue, they're obligate nasal breathers until the first 6 months of life, and this makes sense because a large tongue makes it hard for them to be mouth breathers. They have a narrow nasal passage, and it contributes to 50% of their airway resistance. When you look at their larynx, it's more anterior and superior. So at birth, they typically say that it's located at the C3 level. By 3 years of age, it's descended down to C5, and typically by 10 to 12 years, it's down to the adult level of C6, C7. The epiglottis itself is longer, floppier, and U-shaped. The cricoid is the narrowest part of the larynx, unlike in adults where it's the vocal cord opening which is the narrowest part. After puberty, the cricoid enlarges, and from then on is no longer the narrowest part. The implication here is that if you intubate a neonate, you can get through the vocal cord, but sometimes get resistance at the cricoid level. So typically, in adults where we say you want to go with the largest tube possible, with neonates, you usually err on the safer side and go with a smaller tube as your first attempt. Then when you look at their lower airways, their trachea size can vary from being anywhere between 3 cm to 7 cm, depending on the size of the baby. The bronchi angles are pretty much the same as adults. You have smaller peripheral airways which lead to an increase in airway resistance. You have minimal smooth muscles, so therefore bronchodilation has a minimal effect. And the trachea itself is more easily compressible. In terms of the chest wall, the ribs are more horizontal, so the AP expansion is limited, so you lose that classical bucket handle movement with a transverse expansion. And neonates lack that type 1 muscle fiber. So that type 1 is that slow contracting and highly oxidated fibers that can last for a long time and don't get fatigued over a long period of time. So neonates, when they're sick and they have the increased work of breathing, they'll become fatigued a lot more easier. Finally, their ribs are more cartilaginous, so it's easier to expand their chest and therefore their chest wall compliance is higher. So you can see how there's a lot of physiological changes that occur in the neonate, and this can have major anesthetic implications. Positioning alone is key in neonates, so unlike adults where you want that sniffing position, in neonates you want to put a roll under their shoulder, and this allows their occiput to sit a bit higher and get their head in a neutral position. The neutral position is ideal because of the anterior larynx and the superior larynx, and allows the best view on intubation. Bag masking neonates can be a lot more trickier because they have so much more soft tissue. The one thing you don't want to do is apply the classic CE grip that you do with adults. Pressure under the chin can cause the trachea to compress. So when you're bag masking a neonate, the technique is to do jaw thrust under the mandible and open their mouth passively with the mask. This allows a patent airway passage, and the first time you do it, it's very counterintuitive and harder to place your hands like that. On intubation, because of the floppy epiglottis and the U shape, it can be hard to get into the vallecula and lift the epiglottis up, so a straight blade is preferred to directly lift the epiglottis. When you're selecting a tube size for a neonate, you don't use the rule age divided by 4 plus 4. This applies for over 1-year-olds, The way you select a tube size for a neonate is you look at the gestational age and their weight. So typically over 3 kilos can have a size 4 tube, 2 to 3 kilos is a 3.5, 1 to 2 kilos is a 3, and less than 1 is a 2.5. These ranges are classically described for uncuffed tubes. If you're using a micro cuff, you typically go with a smaller tube, such as a size 3. Importantly here, you also really want to be careful at the distance of the tube at the lips. If you remember 9 to 10 centimeters for a neonate that weighs roughly 3 kilos, that's a good guide that you can put into your answer. Now we're going to look at the last topic in this podcast, which is neonatal physiology. Here I'm going to briefly focus in on the cardiovascular and the respiratory system and quickly touch on temperature management. The important features with the cardiovascular system in a neonate is that they have a higher cardiac output, anywhere between 200 to 400 mils per minute per kilo, and that decreases quite rapidly to around about 150 mils per minute per kilo by 8 weeks. Remember, in an adult, the cardiac output is normally 70 mils per minute per kilo. The neonate heart also is very unique. It has an immature myocardial cell. What this means is that it's not very good at changing its contraction force based on preload. And therefore, the classic term that we say is when we look at the cardiac output, there's a fixed stroke volume and it's heart rate dependent. At birth, the normal neonatal heart rate can be anywhere between 120 to 160 beats per minute. And the other important thing is that the neonatal's peripheral vascular system has a very low resistance. So the blood pressures are typically lower in a neonate than compared to an adult. The implication of these cardiovascular changes is that if a neonate is sick, typically you'll get an increase in heart rate first. The classical signs which you see in an adult where they drop their blood pressure, that's a very late sign in a neonate, and it's a very bad sign in a neonate. Because what a neonate will do is that they'll constrict their peripheral vascular resistance and get all their blood flow to their heart and to their main organs. As a neonate gets sick, you can actually feel them getting cooler and cooler from their fingertips to their elbows to their shoulders. They get that classic mottled appearance. And here, what you don't want to do, which you do in an adult when they get that distributive shock, is give them a vasopressor. Remember, a neonate's cardiac output and stroke volume is essentially fixed. So if you increase their afterload, their heart might crap out. So the resus drug of choice is adrenaline. Now moving on and looking at the respiratory system in a neonate, their minute ventilation is said to be 220 mils per kilo, but the alveolar ventilation is roughly 140 mils per kilo per minute. Their rest rate is higher, 30 to 40 generally, and their tidal volumes are the same as an adult, so between 6 to 8 mils per kilo. The reason the neonate's rest rate is higher is that it minimizes their work of breathing. It's a way to overcome the compliance of the respiratory system, so having fast, shallow breaths aids their respiratory system. Kind of like a restrictive disease pattern rather than an obstructive disease pattern. In terms of their lung volumes, the FRC at birth is 20 mils per kilo, but within the first hour goes to normal adult levels of 30 to 35 mils per kilo. The total lung capacity is the same as an adult, so 70 to 80 mils per kilo. The vital capacity is slightly lower, 45 mils per kilo compared to 60 mils per kilo. And importantly, the closing capacity is higher than the FRC. So with normal tidal volume breathing, you get airway closure occurring. The major implication of this is that with any induction of anesthesia, you're going to get a further decrease in FRC and further increase in your airway closure. So giving PEEP is very important with neonates. That's why when you look at the NeoResus giraffe, they have the settings of 30 by 5 of the peak pressures that they're delivering. You really want that lung to expand and stay expanded, and you don't want to promote atelectasis. In terms of the lung mechanics, we've kind of already touched on it, but the chest wall AP expansion is limited because the ribs are horizontal. So therefore, there's a big reliance on the diaphragm for breathing. The diaphragm is not as efficient because it has less type 1 fibers, so less of those fatigue resistant fibers compared to in adulthood. But the compliance of the chest wall is very compliant because the rib cage is cartilaginous. And this helps because the respiratory muscles themselves are not that well developed. So we typically say that the lung compliance is poor, typically 5 mils per centimeters of water. And as you know in adults, the lung compliance is 200 mils per centimeters of water. Importantly, the specific compliance is similar to the adult. And the other thing which is much higher in neonates is the airway resistance. This is as much as 25 centimeters of water per liters per second. Neonates are obligate nasal breathers, and that's contributing to 50% of the airway resistance. The normal neonate partial pressure of O2 hovers around about 50 to 70 millimeters of mercury, and that's because their VQ matching is not as well as in an adult. So in an adult where you have a VQ ratio around about 0.8 of matching, in a neonate this can be roughly 0.6. And that goes back to their closing capacity being higher than the FRC. Finally, with regards to control of ventilation, there's a lot of conflicting stuff out there with different texts. So Power and Cam state that the chemoreceptors are well developed, but typically you would assume that both the peripheral and chemoreceptors are poorly developed. I would go by what Power and Cam says because that's a recommended text. And here they say that the ventilatory response to CO2 is mature. The CO2 response is shifted to the left, so that ventilation increase occurs at a lower CO2 tension, and the increase in ventilation typically occurs with an increase in tidal volume. In saying that, the chemoreceptors can be more sensitive to anesthetic drugs, so they have more of a depressant effect on a neonate, and therefore can increase the apnea threshold at much lower doses of, say, narcotics and other drugs. The last important thing to quickly touch on is the thermoregulation. Now, newborns' heat balance homeostasis is really affected because of their increased surface area compared to weight ratio. This is 3 times higher than what a normal adult would have. The insulating capacity is decreased, and their shivering mechanism is poorly developed. All of which leads to the fact that the thermoneutral zone is much higher than that of an adult. So an adult's thermoneutral zone sits around about 25 to 28 degrees. The thermoneutral zone for a full-term naked neonate is 32 to 34 degrees, and for a low birth neonate can be as high as 35 to 36 degrees. The significance of which is, if a neonate sits outside of its thermoneutral zone, it's going to increase its oxygen consumption. Therefore, it's really pivotal that you know this and that you increase the temperature for a neonate and really protect their core body temperature and their external temperature. Now, that was a lot to go through in our first section, but it's going to help us as we look at the past SAQs because they're pretty much picking on those topics that we've gone through. So the first question we're going to look at was asked way back in 2014 in the first sitting, and it was, indicate the sequence of physiological changes to the fetal circulation at birth and briefly describe the mechanisms that account for these changes. It had a pass rate of 40%, and the examiner report wanted you to talk about the removal of the placenta, the consequence of this, how the PVR, so the pulmonary vascular resistance, is decreased and the systemic vascular resistance is increased, the changes to the ductus venosus, the foramen ovale, and the ductus arteriosus, and also a discussion of the mechanism of why these changes occur. Additionally, you could get extra marks if you talked about the time scale of these changes, the clinical significance of these changes, and noting that these changes were reversible for specific amounts of time. So that's called a reversion back to a fetal circulation. In my model answer to this question, I would have a brief opening statement that says that birth has significant changes. Central to this is lung expansion and the loss of the placental flow. The fetal circulation is a parallel circulation secondary to the placenta, and the placenta is the source of oxygen and nutrients. At birth, the transition occurs to a circulation in series. The three shunts you should mention here are your ductus venosus. So remember those numbers. From the umbilical vein, 60% of the blood goes into ductus venosus, bypassing the liver and going directly into the IVC. The second shunt is your foramen ovale, which allows 60% of the blood to go from your right atrium into your left atrium. And then you have your ductus arteriosus, which is between your pulmonary artery and your descending aortic arch, and 90% of the blood that gets ejected out of the right ventricle goes through the ductus arteriosus. Overall, the fetal circulation is a high pressure circulation with low flow, and at birth, we move to go towards a low pressure, high flow system. Here is the controversial bit. What changes trigger what is really hard to pinpoint, and I think that's probably the hardest part in this model answer. I don't think you have to write stepwise changes. You can just write all these changes occur simultaneously and are important as they all contribute to each other. So in my head, I like to think about the first breath as the first change because that's just the easiest one for me to remember. So breathing leads to an increase in partial pressure of O2, a decrease in partial pressure of CO2, a decrease in hypoxic pulmonary vasoconstriction, and a decrease in pulmonary vascular resistance. So all this means that the alveoli expand and increased blood goes through the lungs. So our right ventricle afterload pressure is decreased and less blood flow is going through the ductus arteriosus. Secondly, there's the cord clamping followed by the removal of the placenta. So here there's the physical clamp, and then this essentially leads to an increase in systemic vascular resistance. So you're increasing that left-sided heart pressure, and you're also losing the maternal prostaglandins. Those are going to be important in closing your ductus arteriosus. At the same time as the umbilical artery and the vein are clamped, you're getting less blood flow in through to the IVC, so our right atrial pressures are decreasing. With this leads to the closure of the patent foramen ovale, and that closure happens within minutes, but permanent closure takes 4 to 6 weeks to occur. Then we've got to finish off this answer by talking about the ductus arteriosus closing. That's closing because of two reasons: the increased partial pressure of oxygen and the decreased prostaglandins. The closure occurs within 10 to 15 hours, but permanent closure can take up to 3 weeks. So it's usually half the time of the foramen ovale to be permanently closed. You can also mention the ductus venosus, and that becomes the ligamentum venosum, and we don't know the exact mechanism why that occurs. And then we have the ongoing changes at birth. So now the RV, which was the same size as the LV, becomes smaller, and the LV starts to become bigger and have more muscle to it. Overall, the neonatal circulation will have a higher heart rate, 120 to 160 beats per minute. Its cardiac output will be high, 280 mils per kilo per minute. Its stroke volume will be fixed. It'll have a low systolic blood pressure between 70 to 90 millimeters of mercury. And all these changes that transition a fetal circulation into a neonatal circulation can be reverted if the left sided pressures drop and the right side heart pressures increase. And this is called a reversion to fetal circulation. So just to make sure we understand that, a decrease in partial pressure of O2, so if your lungs don't open up, a higher CO2, a lower pH, a lower temperature, all will keep the pulmonary vascular resistance high, so you don't get that transition occurring. Then the next SAQ, which was asked in 2016 and then repeated again in 2021 in the first sitting, which has a pass rate now of 70%, was describe the anatomy of the neonatal airway and what implications this has for airway management. As per the examiner report, you needed to divide this question up into two parts: the description of the neonatal airway and the implications of the mentioned features of the airway management. It was important to address the size, the shape of the occiput, the relative size of the tongue in context of the oral cavity, a description of the epiglottis, the position of the larynx and the description of the shape and relative size of the larynx and the cricoid. As per the examiner report, there was relatively few facts that you actually needed to incorporate into this question. So the facts that you put in, you needed to have precise language of each of the features. So I think this question lends itself to a table really well. And in that table, you have those subheadings. And whether you want to just divide the subheadings as upper airway and lower airway to make it easy, and then on the other side have implications, or you want to do it the way I like to think about it, which is external anatomy, upper airway, larynx, lower airway, and then chest. Doesn't really matter. Really, you just need to figure out a way that you'll remember all the key points. So here we want to mention those points of the large occiput externally, the angle of the mandible being less acute, the small mouth opening, and all these lead to the way you position a neonate in the optimal position, not like an adult in a sniffing position. The important features on the upper airway is that they're obligate nasal breathers, they have that large tongue, they're edentulous, so some of these features are actually beneficial. So the fact that they have no teeth is beneficial, but the fact that they have a large tongue makes it harder to move the tongue away and swipe it, and they are more at risk of having an obstruction. You really want to make sure that the nasal passage is not blocked, so good suctioning on the nasal passage is important. And then the way you hold the mask is different. You don't want to use your CE grip. You want to use that pressure on the back of the TMJ and move the jaw forward. So jaw thrust is more important rather than chin lift. If you do the chin lift, you'll get the trachea compression occurring. Then when you look at the larynx, you want to say that the larynx is positioned more anteriorly and superiorly at the level of C3. And so the implication this has is that when you put the blade in, you want to be careful and precise and say that you'll carefully position the laryngoscopy blade, making sure that you don't go too far into the patient's cavity past the vocal cords. The other implication is that you might use a straight blade and lift the epiglottis directly up to improve your view. Then you can also mention how the cricoid is the smallest area, so the implication this has on tube selection, and that the tube might go through the vocal cords but get caught in the cricoid area. So you preferentially pick a tube that might have a smaller size. Now, whether you talk about the lower airways in length with this question can be up for debate. Technically, this question is asking about the neonatal airway and mentioning things like the ribs are less ossified, there's less type 1 fibers. I don't know how much that actually overlaps with actually talking about neonatal airway. What I think is important is specifically mentioning your selection of your endotracheal tube in a neonate and how that differs from if they're 1 year old or above. So here, that age over 4+4 formula doesn't work. So you want to use the gestational age plus the weight. The other thing that I think is important to mention is the use of external laryngeal maneuvers to help augment and improve your airway grade in a neonate. So because of the fact that the trachea and soft tissue is so compressible, a burp might not be appropriate. So you might use something that's more of a gentler technique, such as using your pinky finger to help improve the view. I think that would be a good clinical implication to put in. Now, the last SAQ I want to look at was asked way back in 2013 with a really poor pass rate of 5%. It was compare and contrast the lung function in a neonate versus that of an adult. The examiner report said that to achieve a full marks, the most efficient way was to display this answer in a table format. The main points expected were a definition of a neonate, the physiological relevant anatomy, the mechanics, which involved the compliance, lung volumes and resistance, the ventilatory parameters, gas exchange, and control of breathing. There were extra marks if you could demonstrate physiological relevance. So an example would be an obligate nasal breather is a neonate with high upper airway resistance, which provides auto-PEEP, and other additional marks could be gained with brief mentioning of the non-respiratory functions of the lung. This is a really tough SAQ, and the fact that it was only 5% pass rate does increase the suspicion of it being asked again. However, the trick here is you don't want to put too much information or spend too long in one particular area. As you can imagine, just talking about the neonatal airway anatomy is a whole question on itself. So the way I would structure this question is have the table format, and then have neonate on one side with a definition of 1 to 28 days, and then adult on the other side. Anatomy, you want to quickly put in those points of external, upper airway, larynx, and lower airway, and you want to compare them really quickly to the adult. Then you want to move on and talk about lung volumes. So you can say that the alveolar ventilation is 140 mils per kilo per minute, while in adults this is 70 mils per kilo per minute. The respiratory rate is much higher, 30 to 40, and the tidal volume is the same. The FRC is the same at 30 mils per kilo, but the vital capacity is lower. And the important feature that's different is that the closing capacity is higher than the FRC in a neonate versus in an adult. So the implication of this is that you get airway closure with normal tidal volume breathing. Then when you look at the mechanics of breathing, you can say that the airway resistance is higher. The actual airway resistance numbers is that the airway resistance in a neonate is 25 centimeters of water per liter per second, and in an adult this is roughly 2. In terms of compliance, the lung compliance is much lower in a neonate, roughly 5 mils per centimeter of water. In an adult, it's 200 mils per centimeter of water. The chest wall compliance is increased. The specific compliance is the same. And the total compliance, so the combination of your lung compliance and your chest wall compliance, is roughly 1/20th of that of an adult. For gas exchange, your PaO2 is lower at 70 due to the increase in the VQ mismatch. So the mismatching is nearly double the amount in an adult. But to compensate in a neonate, you do have the increased amount of fetal hemoglobin circulating around. In terms of control of ventilation, there's the left shift of your CO2 minute ventilation response curve. I think the important point to put here is that with the control of ventilation, regardless, in a neonate, they have a decreased reserve to increase minute ventilation because of the fact that they're already breathing at such a high resp rate. I think overall with this question, there are some important numbers you need to remember and be able to regurgitate if this question comes up again. So VQ matching in an adult versus neonate. Adult is 0.8, neonate is 0.4 to 0.6. The normal PaO2 in a neonate is 70, an adult is roughly 100. The normal resp rate in a neonate is 40. The normal alveolar ventilation is 140 in a neonate, so double that of what an adult is. The normal airway resistance is 25 compared to 2 in an adult. The normal compliance of the lung is 5 mils per centimeters of water compared to 200. And the one other number that we haven't talked about is that the tidal volume dead space is slightly increased, roughly to 1/3 to a half of a normal tidal volume breath. So you can see how this question is a really hard one to answer because it requires both rote learning a lot of those numbers as well as knowing some of those facts that differ from neonate versus an adult. That brings us to the end of the recent SAQs regarding this topic, and now we can look at some past opening viva stems. The last opening viva question regarding the fetal circulation was asked in the 2022 first sitting, and the question was, what are the shunts in the fetal circulation? I think this would be a really nice, good viva stem to get, because you can easily list out the ductus arteriosus, the ductus venosus, and the foramen ovale. The variation to this is, what are the differences between the fetal circulation and the neonatal circulation? This was asked in 2023 second sitting, and essentially it's just a variation on the same question. Here you're just saying that the fetal circulation is a circulation that occurs in parallel, while the neonatal circulation is a circulation that occurs in series. The main reason for this is the shunts that are present within the fetal circulation. You mentioned those 3 shunts, and you say that the fetal circulation is a low volume, high pressure circuit, while the neonatal circulation is a high volume, low pressure circuit. The tricky opening stem regarding fetal circulation would be the one that they got in 2019 second sitting, which was, can you show me on this diagram how blood flows through the fetal heart? So if you imagine blood coming through the umbilical vein, 60% going through the ductus venosus, 40% through the liver, of that all joins up to the IVC. From the right atrium, 60% goes through the foramen ovale into the left atrium, 40% down the right ventricle. From the right ventricle, 90% goes through the ductus arteriosus, joining into the descending aorta, 10% into the lungs in the pulmonary circulation. Going back onto the left-hand side, you have the small amount of blood returning from the pulmonary circulation, but majority of the blood coming from the foramen ovale. From that, you get ejection out of the left ventricle, with majority of the high oxygenated blood at 65% saturations going to the brain and also supplying the heart itself. Then moving on, as we look into the past stems regarding the neonatal airway, in 2014 second sitting, the stem was, you are asked to anesthetize a 2-day-old baby for an urgent laparotomy. How does this neonatal airway and respiratory system differ from that of an adult? So really this question is asking you that really complex SAQ. So you need to have a quick system, and for me, like I said, it's external, upper airway, larynx, lower airway, and the respiratory system, you can think about the lung mechanics, the gas exchange, and the control of ventilation. Then to finish off the vivas, we have the viva stems that relate to the physiology of the neonate. In 2023 and 2022, they were asked, what are the cardiovascular changes that occur in a neonate immediately following birth? This is a very similar question, or just another way to ask, what are the changes between the fetal circulation and the neonatal circulation? In contrast, in 2019, they were asked, what respiratory changes occur at birth in a neonate? And here, the importance is knowing what happens with the first breath. So if I was to answer this question in a viva setting, I would say there are many changes that occur within the respiratory system at birth in a neonate, and they occur with the initiation of the first breath. Due to this, the lung volume expands, the partial pressure of oxygen increases, the partial pressure of CO2 decreases, and the pulmonary vascular resistance decreases. This leads to a flow-on effect of changes in lung mechanics, control of ventilation, and gas exchange. And I would leave my answer there and let the examiner then guide me down the path. I think the trick there is to show a bit of knowledge so that the examiner knows that you know the topic, but not to show your cards too early. And again, these are just my techniques on how I would answer the viva stems. You need to figure out your own way and what works well with the way that you speak so that you can deliver the information in the best way possible. Today has been a jam-packed mini-pod, and we've covered a lot of topics with a lot of core content. I want to thank you guys again for listening to the episodes, and I hope this mini-pod has been useful. If you have any questions regarding the exam or what we've discussed on the pod, just email me at anirudh@sweetdreamsanesthesia.com. And for a short while, this is goodbye, but I'll see you guys again with another pod in 6 months' time. Till then, good luck with your studying, and good luck to all the candidates that'll be sitting in 2024 first sitting.